Okay, let's unpack this. Imagine a system deep inside your brain that's not just cradling it in fluid, but also constantly cleaning, nourishing, and protecting it from the outside world. Today, we're embarking on a truly comprehensive deep dive into that internal world. The brain's intricate ventricular system, the cerebrospinal fluid that fills it, and, well, the incredible barriers that act as its vigilant gatekeepers. We're really going beyond the basics here, exploring every detail of this crucial system so you can truly master this complex yet vital information, like the elite professionals in the field.
What's truly fascinating here is how fundamentally these systems underpin brain health and how quickly their disruption can lead to, well, serious conditions. Think back to our opening scenario. That 26-year-old woman admitted to the ER after a severe head injury. She's unconscious. Her physician performs a spinal tap, and the fluid, it's not clear. It's uniformly blood-stained across multiple samples. That's an immediate critical red flag. Points directly to a subarachnoid hemorrhage. Understanding why that blood-stained CSF is so significant and what it tells you about the brain's internal environment, that's precisely the kind of mastery we're aiming for today.
Absolutely. This deep dive is for you to arm you with a professional level understanding of these critical neuroanatomical and physiological concepts. We're laying the foundation for true expertise, starting with the very chambers of the brain. So let's begin with the brain's inner sanctum, the ventricular system. At its simplest, these are what? Four fluid-filled cavities nestled within the brain. What's the core identity of these chambers?
Right. Their core identity is that they're all lined throughout with a specialized membrane called ependyma. And critically, they are continuously filled with cerebrospinal fluid, or CSF. Developmentally, it's actually quite elegant. These chambers are direct remnants of the cavity, the embryonic neural tube.
Ah,
This
yeah.
is the very earliest precursor of your brain and spinal cord. That foundational origin, well, it tells you just how integral they are.
And these aren't isolated pockets, right? They're a highly interconnected network. Let's start with the largest, the lateral ventricles. What should we really grasp about their unique shape and location?
The key is their distinct C shape. There's one in each cerebral hemisphere, and this shape isn't arbitrary. It allows them to curve through multiple brain lobes. So each lateral ventricle is divided into a central body, which sits within the parietal lobe, and then three horns that extend out. An anterior horn reaching into the frontal lobe, a posterior horn into the occipital lobe, and an inferior horn curving down into the temporal lobe. Understanding this C shape really helps visualize how extensively they interact with different brain regions.
And they don't just sit there, they flow into the next chamber, right?
Precisely. From each lateral ventricle, CSF flows into the third ventricle via a crucial connection point, the interventricular foramina. You'll often hear them called the foramina of Monroe.
Okay, Monroe.
Now, if you want to truly master the anatomy, let's dive a bit deeper into the lateral ventricles themselves. The body of the lateral ventricle, for instance. Its roof is formed by the undersurface of the corpus callosum.
That big connector between hemispheres.
Exactly, that massive band of nerve fibers. Its floor is composed of the body of the caudate nucleus and the lateral margin of the thalamus, both critical, deep brain structures. And medially, its wall is partly defined by the septum pellucidum anteriorly. It's here, within the body, that the choroid plexus begins to project into the ventricle.
Ah, the CSF factory we mentioned.
Right, through a slit-like opening called the choroidal fissure. And that's a really important detail because that's where a lot of the CSF production starts.
That's a lot of intricate detail, but you can already see how these specific boundaries relate to major brain structures. What about those individual horns?
Good question. The anterior horn, projecting into the frontal lobe, also has its roof formed by the undersurface of the anterior corpus callosum, specifically where its anterior bend, the genu, helps form the forward limit. The floor here is the head of the caudate nucleus, and its medial wall is defined by the septum pellucidum and the anterior column of the fornix. Moving back to the posterior horn, extending into the occipital lobe, both its roof and lateral wall are formed by specialized fibers of the corpus callosum called the tapetum.
Tapio, okay.
With optic radiation fibers running just lateral to that. On its medial wall, you'll find two significant elevations. The bulb of the posterior horn, which is actually formed by fibers of the splenium, the posterior part of the corpus callosum, as they form what's called the forceps major.
Forceps major.
And then the calcar avus, which is a projection caused by the indentation of the calcarine sulcus. That's a key sulcus on the medial surface of the occipital lobe, involved in visual processing. These aren't just names to memorize. They show how the ventricular system is molded by and nestled within the brain's architecture.
And finally, that fascinating inferior horn that curves down into the temporal lobe. How is it structured?
Right, the inferior horn. Its roof is formed by the inferior tapetum and the tail of the caudate nucleus, which, interestingly, terminates at the amygdaloid nucleus.
Ah, emotions and memory centers.
Exactly. Also contributing to the roof is the stria terminalis, another fiber pathway associated with the amygdala. The floor of the inferior horn is formed laterally by the collateral eminence, an elevation caused by the collateral fissure, and medially by the hippocampus.
Key memory structure.
Absolutely vital for memory formation. It's composed of gray matter, but its ventricular surface is covered by a thin layer of white matter called the alveus. Axons from the alveus then gather form the fimbria, which becomes contiguous with the posterior column of the fornix, another key memory pathway. And of course, the lower part of the choroid plexus of the lateral ventricle extends right into this horn.
Wow. That's a truly detailed tour of the lateral ventricles. Impressive. Moving on, what about the third ventricle?
The third ventricle is much narrower. It's a slit-like cavity situated right between the two large thalami.
The brain's relay station?
Pretty much, yeah, the primary relay station for sensory info. Its vital connections are anteriorly with the lateral ventricles via those interventricular foramina we just discussed.
Foramina of Monroe.
Got it. And posteriorly, it connects directly with the fourth ventricle.
And that connection to the fourth ventricle is the cerebral aqueduct, or aqueduct of Sylvius. That's a name many might recognize. What's crucial to know about this particular channel?
Well, it's a narrow channel, only about 1.8 centimeters long. And it's absolutely critical because it serves as the sole conduit for CSF flow between the third and fourth ventricles. It's lined with ependema, surrounded by central gray matter. But here's a key distinction for, that professional level understanding. Unlike the other ventricles, the cerebral aqueduct does not have a choroid plexus.
Ah, no CSF production there.
Exactly, which makes it a particularly vulnerable point for blockages. That's clinically very important.
That makes sense. And finally, the fourth ventricle, often described as tent-shaped. Where is it located, and how does it connect to the rest of the system?
So the fourth ventricle is positioned anterior to the cerebellum and posterior to the pons and the superior half of the medulla oblongata. It's continuous superiorly with the cerebral aqueduct we just mentioned, and inferiorly with the central canal of the medulla oblongata and spinal cord. Its lateral boundaries are formed by the inferior cerebellar peduncle caudally and the superior cerebellar peduncle cranially. These are major tracts connecting the brainstem and cerebellum.
Okay.
The posterior wall, or roof, is indeed tent-shaped, projecting up into the cerebellum. Its superior part is formed by the medial borders of the two superior cerebellar peduncles and the superior medullary velum. The inferior part is a thin sheet of ependema and pia mater called the inferior medullary velum.
And this roof, as you mentioned, is absolutely crucial for the entire system's function because it houses the primary outflow pathways for CSF.
Precisely. This is a point of really deep clinical relevance. The roof is pierced in the midline by the large median aperture, also known as the foramen of Majandi.
Right.
Additionally, there are two lateral openings, the foramen of Luschka, located out at the lateral recesses.
Luschka, okay.
These three openings are the vital exits. They allow CSF to flow from the internal ventricular system out into the subarachnoid space, which surrounds the brain and spinal cord. Without these, pressure would build up inside very quickly.
Right.
Beneath this roof lies the rhomboid fossa, the diamond-shaped floor of the fourth ventricle. It's formed by the posterior surfaces of the pons and the cranial half of the medulla oblongata, divided right down the middle by a median sulcus.
And the floor itself is packed with important structures. What are some of those key features that an elite professional would recognize?
Absolutely. On each side of that median sulcus, you'll find the medial eminence, which is bounded laterally by the sulcus limitans. Just lateral to the sulcus limitans is the vestibular area.
Okay.
Exactly. The vestibular nuclei lie right beneath it, crucial for balance. You might also see a slight elevation called the facial colliculus that's caused by the facial nerve's motor fibers looping over the abducens nucleus. At the superior end of the sulcus limitans is the substantia ferruginea, a kind of bluish-gray area of melanin-pigmented nerve cells. Then there are the striae medullaris nerve fibers, originating from the arcuate nuclei that pass laterally toward the inferior cerebellar peduncle. Inferior to these stria, you find two triangles. Hypoglossal triangle, indicating the underlying hypoglossal nucleus for tongue movement.
Okay.
And the vabal triangle, indicating the dorsal motor nucleus of the vagus, vital for many autonomic functions. And finally, the area postrema. It's a narrow region between the vagal triangle and the lateral margin, just rostral to the central canal opening.
And you mentioned this area is special regarding the blood-brain barrier.
Exactly. It's one of the few places in the brain where the blood-brain barrier is naturally weaker or leaky. This allows us to sample blood chemistry directly, which is important for functions like regulating vomiting.
That's an incredible amount of anatomical detail, but understanding these precise locations really helps appreciate the brain's internal geography.
So with all these chambers and connections, where does the CSF itself come from? This brings us to the choroid plexuses, the brain's very own CSF factories.
Exactly. The choroid plexuses are these highly vascular fringe-like structures. They're composed of pia mater covered with that specialized ependymal lining. They project into the lateral, third, and fourth ventricles, usually on their medial aspects. Their structure is really key to their function. A highly folded surface, giving lots of surface area, with a core of vascular connective tissue covered by cuboidal ependyma. These epithelial cells have microvilli, again increasing surface area, and importantly, the blood capillaries within the plexus are separated from the ventricular lumen by their endothelium, a basement membrane, and that surface epithelium. This whole specialized setup is what allows them to perform their primary function, producing CSF.
And what about their blood supply and drainage? That seems important too. Very important. For the third and lateral ventricles, the blood supply comes from choroidal branches of the internal carotid and basilar arteries. For the fourth ventricle, it's supplied mainly by the posterior inferior cerebellar arteries. Venous drainage is via the internal cerebral veins, which merge into the great cerebral vein, then to the inferior sagittal sinus, and finally into the straight sinus. Knowing these pathways is crucial if you're dealing with issues like hemorrhage or vascular malformations that could affect CSF production.
Lastly, before we move to the fluid itself, let's just touch on the central canal. This is essentially an extension of the ventricular system, reaching right down into the spinal cord.
Correct. It opens superiorly to the fourth ventricle and then extends through the inferior medulla oblongata and the entire length of the spinal cord. At its very inferior end, within the conus mesioris, it has a small dilation called the terminal ventricle. Like the other ventricles, it's lined with ependyma and filled with CSF surrounded by the great commissure. But just like the cerebral aqueduct, it crucially does not have a choroid plexus.
So no CSF production there either.
Right. No CSF production in the central canal.
Okay, so we've mapped the internal chambers. Now let's talk about the fluid itself. Cerebrospinal fluid, CSF. What exactly is it and what are its properties?
Well, CSF is found not only within the ventricles, but also in the subarachnoid space that completely envelops the brain and spinal cord. The total volume is actually quite small, only about 150 millimole in an adult.
Really? That seems small for cushioning the whole brain.
It does, but it's constantly circulating and being replaced. Appearance-wise, it's distinctly clear and colorless, almost like water. Its composition is remarkably stable. It contains inorganic salts and concentrations pretty similar to blood plasma, but glucose is only about half the concentration found in blood, and there's only a trace of protein.
Yeah.
Under normal conditions, you'd find very few cells. Typically 0 to 3 lymphocytes per cubic millimeter.
So it's very clean fluid.
It's extremely clean, yes. Its pressure is also very carefully maintained, usually ranging from 60 to 150 millimeters of water when measured via a spinal tap with the patient lying down. This pressure can fluctuate, though, with things like straining, coughing, or even if you compress the internal jugular veins.
That sounds like a carefully regulated, almost pristine environment. So what exactly does CSF do for us? What are its critical functions that an elite professional would understand?
It performs multiple, absolutely indispensable roles. First and foremost, it acts as a cushion and protector. It provides a vital buffer between the delicate CNS tissue and the hard bones of the skull and vertebral column. Protects against bumps and jolts.
Mechanical shock absorber.
Exactly. Secondly, it provides buoyancy and support. The brain's density is only slightly greater than CSF, so it effectively floats in it. This massively reduces its effective weight.
Oh, interesting.
Yeah, preventing it from compressing nerves and blood vessels at the base of the skull just due to its own weight. Thirdly, it acts as a reservoir and helps regulate skull contents. For instance, if there's a sudden increase in brain volume, maybe from swelling or blood volume, the CSF volume can temporarily decrease to help compensate, maintaining a more constant intracranial pressure. Beyond just physical protection, CSF is an ideal physiological substrate, actively participating in the nourishment of nervous tissue.
How so?
Well, it provides a stable ionic environment and helps transport necessary nutrients. And crucially, it assists in the removal of metabolic waste products from neuronal activity, gets rid of the brain's garbage. There's even a theory, though it's still being explored, that it might act as a pathway for pineal secretions to influence the pituitary gland via circulation through the third ventricle.
Okay, here's where it gets really interesting for mastery. How is this vital fluid actually formed, and what's the mechanism behind it?
The primary sites, as we discussed, are the choroid plexuses in the lateral, third, and fourth ventricles. There are minor contributions, too, from ependymal cells lining the ventricles, and maybe even from the brain substance itself via perivascular spaces. But the plexuses do the heavy lifting. The mechanism is key. The choroid plexuses actively secrete CSF. It's not just passive filtration from blood.
Active secretion, so energy dependent.
Yes, it requires energy. This active secretion creates a small pressure gradient that helps drive flow. They also have specialized transport systems that actively pump certain nervous system metabolites out of the CSF and back into the blood. This active transport explains why things like potassium, calcium, magnesium, bicarbonate, and glucose are found in lower concentrations in CSF compared to blood plasma. It's a highly controlled, manufactured environment.
Makes sense.
CSF is produced continuously at a rate of about 0.5 millibils per minute. That adds up.
So doing the math, 0.5 millimins times 60 Minsure times 24 these days. That's over 700 millibils a day.
Around that, yes. Which means the entire 150 milliliter volume is completely replaced or turns over roughly every 5 hours. And this is a critical point for clinical understanding. CSF production is not pressure regulated. It just keeps churning out at this steady rate, even if its reabsorption pathway is blocked.
Ah, and that's why blockages cause pressure buildup.
Exactly. That has huge clinical consequences like hydrocephalus, which we'll get into.
So it's constantly being made, which means it also needs a constant exit route.
Yeah.
How does CSF circulate through this elaborate system, and what helps it on its journey?
Okay, the journey. It begins with secretion from the choroid plexuses within the ventricles lateral, third, and fourth. From the lateral ventricles, CSF passes into the third ventricle via those interventricular foramina, the foramina of Monroe. Then, from the third ventricle, it flows through the narrow cerebral aqueduct into the fourth ventricle. This initial circulation within the ventricles is aided by a couple of things. The pulsatile action of arterial blood within the choroid plexuses kind of acts like a gentle pump, and also by the beating cilia on the ependymal cells lining the ventricles.
Cilia, like tiny hairs pushing it along.
Exactly. Tiny hair-like structures helping to move the fluid. From the fourth ventricle, the CSF finally exits the internal ventricular system into the subarachnoid space through the median aperture, ossia agendi, and the two lateral foramina, luschka.
So once it's out of the ventricles and into the subarachnoid space, where does it go from there? It's surrounding the whole brain and spinal cord now.
Right. It then moves through specific expansions of the subarachnoid space called cisterns. Think of them like pools or reservoirs. The big ones are the cerebellomedullary cistern and the pontine cistern at the base of the brain. From there, it flows generally superiorly, up through the tentorial notch to reach the inferior surface of the cerebrum. It continues to move superiorly over the lateral aspect of each cerebral hemisphere. This upward flow is further assisted by the pulsations of the cerebral arteries that run within that subarachnoid space.
Arterial pulsations helping push it up.
Yeah, it's thought to contribute. Some CSF also moves inferiorly within the subarachnoid space, down around the spinal cord and the cauda equina. Down there, its circulation is influenced by spinal artery pulsations, movements of the vertebral column itself, respiration, coughing, even just changing your body position. And it's not just a surface fluid. CSF also penetrates into the nervous tissue itself along the perivascular spaces, these tiny channels around blood vessels.
So it circulates all around, but it also has to be reabsorbed back into the bloodstream to maintain that constant volume and pressure. How does this reabsorption happen? Where does it go?
The primary sites for CSF absorption are specialized structures called arachnoid villi. These are small projections of the arachnoid mater, part of the subarachnoid space, that actually protrude into the large dural venous sinuses.
The big veins draining the brain.
Exactly, especially the superior sagittal sinus, which runs along the top midline of the brain. These arachnoid villi often cluster together to form larger visible structures known as arachnoid granulations. You can sometimes see them on imaging or dissection. Structurally, each villus is basically a little outpouching of the subarachnoid space that pierces through the dura mater. Its tip is covered by a thin cellular layer and then overlaid by the endothelium, the lining of the venous sinus. The mechanism is fascinating and largely passive. Absorption occurs when CSF pressure in the subarachnoid space is higher than the venous pressure within the sinus.
So it flows down a pressure gradient.
Right. Electron microscopy suggests there are fine tubules lined with endothelium within these villi that permit a direct bulk flow of CSF from the subarachnoid space straight into the venous blood.
That sounds like a sophisticated one-way valving mechanism.
It absolutely is. The arachnoid villi act like one-way valves. If the venous pressure happens to rise above the CSF pressure, the tips of the villi get compressed. This compression effectively closes off those tubules, preventing blood from refluxing back into the subarachnoid space. Very clever design.
Neat.
While the arachnoid villi are definitely the main players, some minor absorption probably also occurs directly into smaller veins within the subarachnoid space, and possibly through the perineural lymph vessels that surround cranial and spinal nerves. But this is another critical point for professional understanding. Because CSF production is constant, it is the rate of CSF absorption through these arachnoid villi that directly controls the overall CSF pressure.
So if absorption is impaired,
Pressure goes up, exactly.
Okay.
Any interference with this absorption process can quickly lead to problems like increased intracranial pressure.
now that we understand the internal flow of CSF and its reabsorption, let's turn our attention to the subarachnoid space itself. You said it's the CSF's external home. How do we define this space more precisely?
Okay, the subarachnoid space. It's simply the interval, the space, located between the arachnoid mater and the pia mater, the two inner layers of the meninges.
Middle and innermost layers.
Right. Think of it as a fluid-filled envelope that completely surrounds both the brain and the spinal cord. It's filled with CSF, as we've said, but it's also where you'll find the large blood vessels that supply the brain running along the surface before they dive in. The space isn't just empty fluid, though. It's traversed by a delicate network of fine connective tissue strands called trabeculae. These kind of help suspend the brain within the fluid, giving it some structural support.
And it's not a uniform space everywhere, is it? It expands in certain areas to form those important cisterns you mentioned.
Correct. In specific regions, particularly around the base of the brain, the arachnoid mater doesn't hug the brain's surface quite as closely as the pia mater does. This creates these enlarged areas, these pockets of subarachnoid space known as subarachnoid cisterns. The largest and most clinically relevant ones include the cerebellomedullary cistern, also called the cisterna magna, located behind the medulla and cerebellum,
Cisterna magna? Okay.
the pontine cistern at the base of the pons, and the interpeduncular cistern, which sits between the cerebral peduncles. These are important reservoirs for CSF flow, and sometimes they're accessed for diagnostic procedures, like drawing CSF.
And it extends along nerves, too, fascinatingly. You mentioned the optic nerve.
Yes, it truly does. It extends along the olfactory nerves all the way out to the nasal mucoperiosteum. It also follows cerebral blood vessels as they dive into or emerge from the brain substance, forming those perivascular spaces, though these extensions stop where the vessels become tiny arterioles or venules. Inferiorly, it extends well beyond the lower end of the spinal cord itself, surrounding the bundle of nerve roots called the cauda equina. It typically terminates down around the S2 or S3 vertebral level.
Which is why lumbar punctures are done lower down, below the spinal cord.
Precisely, to access this CSF-filled space safely. It also surrounds cranial and spinal nerves, following them until they exit the skull or vertebral canal, at which point the arachnoid and pia mater fuse with the nerve's outer sheath, the perineurium. And that specific extension around the optic nerve is particularly significant. A sleeve of subarachnoid space surrounds the optic nerve all the way to the back of the eyeball, where the arachnoid and pia fuse with the sclera, the white part of the eye. This is clinically super important because the central artery and vein of the retina have to cross this CSF-filled space to get into the optic nerve.
Ah, so pressure changes in the CSF can affect those vessels.
Exactly. It makes the back of the eye a window into intracranial pressure, which we'll come back to with papilledema.
So we have this sophisticated fluid system, wonderfully cushioned and constantly circulating. But it's not just passively contained, it's guarded by a remarkable set of gatekeepers. The blood-brain barrier, BBB, and the blood-cerebrospinal fluid barrier. Why are these barriers so absolutely essential for the brain's function?
Well, the central nervous system. It demands an incredibly stable and tightly controlled environment to function optimally. Neurons are very sensitive to fluctuations in ions, hormones, toxins, etc. These barriers provide that stability by meticulously, selectively isolating the delicate nervous tissue from the constantly changing environment of the circulating blood. Think of it like a highly exclusive, very well-guarded club where only certain approved guests are granted entry.
Let's start with the blood-brain barrier, the BBB. It's famous for a reason. Paul Ehrlich's experiments back in 1882 were foundational, weren't they? He showed that vital dyes injected into living animals stained almost all body tissues except the brain and spinal cord. What did that tell us, and what are the basic rules of permeability for the BBB?
Yeah, that discovery was absolutely pivotal. We now understand that the BBB's permeability is generally inversely related to molecule size. So smaller molecules tend to have an easier time crossing and directly related to lipid solubility, how fat-loving a molecule is.
Lipid solubility.
So gases like oxygen and carbon dioxide and water pass readily, diffusing easily. Glucose and electrolytes pass more slowly, often needing specific transporter proteins embedded in the barrier. But plasma proteins and other large organic molecules, think things with molecular weights of about 60,000 or higher, are almost completely blocked. They're impermeable. Trypan blue, the dye Ehrlich used, actually binds tightly to albumin, which is a large plasma protein. That binding beautifully explained why the dye itself was excluded from most of the brain. It was piggybacking on something too big to get in.
So what's the structural secret behind this exclusivity? What physically creates the BBB at the capillary level?
Okay, structurally, if you look closely with an electron microscope, the lumen, the inside of a brain capillary, is separated from the extracellular spaces around neurons and glial cells by three key components. First, the endothelial cells themselves, which form the wall of the capillary. Second, a continuous basement membrane surrounding that capillary. And third, the foot processes of astrocytes, a type of glial cell, which adhere very tightly to the outside of the capillary wall.
So multiple layers.
Multiple layers, yes. But the key finding for a professional understanding, the real gatekeeper, is the presence of tight junctions that form continuous belt-like seals between these endothelial cells. Unlike capillaries in most other parts of the body, which might be leaky or have gaps, these tight junctions in the brain prevent substances from simply sneaking between the endothelial cells.
They seal the gaps.
They completely seal the intercellular gaps. This effectively creates a continuous lipid bilayer. The cell membranes fuse together encircling the capillary lumen, which physically isolates the brain tissue. This is precisely why lipophilic molecules, those that are fat-soluble, can diffuse readily across this barrier through the cell membranes, while hydrophilic molecules, water-soluble ones, unless they have a specific transporter, are largely excluded. It's also worth noting that peripheral nerves have a similar, though maybe slightly less stringent, protective structure called the blood-nerve barrier, also relying on tight junctions in their capillaries.
But the BBB isn't a completely uniform monolithic barrier throughout the entire brain, is it? You mentioned earlier there are certain areas where it's different or even absent. Why is that?
That's a crucial distinction for mastery, absolutely. There are specific, specialized brain regions, sometimes called circumventricular organs, where the capillary endothelium actually contains fenestrations, little windows or pores, allowing proteins and small organic molecules to pass much more freely between blood and brain tissue. These are the areas that do become stained by vital dyes, like trypan blue, indicating a different or absent BBB. They include places like the pineal gland, the posterior lobe of the pituitary gland, the tuberous cinereum, part of the hypothalamus, the wall of the optic recess, also hypothalamic, and that vascular area postrema in the medulla we talked about earlier, on the floor of the fourth ventricle.
And there must be a reason for this leakiness.
Definitely. The significance, particularly in the hypothalamic regions and the area postrema, is profound. It allows neuronal receptors in these specific areas to directly sample the chemical content of the plasma, things like hormone levels, osmolarity, toxins. This is vital for regulating things like fluid balance, metabolism, and protective reflexes like vomiting, while still protecting the core nervous tissue elsewhere in the brain. The full significance in the pineal gland is still being worked out, but it likely allows for a closer relationship between the gland's hormone production, like melatonin, and plasma hormone concentrations.
And is the BBB always fully developed right from birth?
Good question. It is present in the newborn, but it's generally understood to be somewhat more permeable to certain substances than it is in the adult brain. This has important implications for things like jaundice affecting the brain in newborns, or how certain drugs might cross more easily in infants.
Okay, so that's the BBB. Next, we have the blood-cerebrospinal fluid barrier. Is it structured similarly to the BBB, and what are its unique properties?
It shares functional similarities with the BBB, yes. It allows water, gases, and lipid-soluble substances to pass pretty freely from blood into the CSF within the ventricles. But it also tightly excludes macromolecules like proteins and most sugars, other than glucose, from entering the CSF. It maintains that pristine CSF composition. Structurally, though, it's a bit different. If you look closely at a choroid plexus villus, the lumen of a blood capillary inside the villus is separated from the CSF in the ventricle lumen by several layers. First, the endothelial cells of the capillary, but here's a difference. These are often fenestrated, meaning they have those pores.
So the capillaries themselves are leaky here.
Yes, unlike in the BBB proper. Then there's a continuous basement membrane around the capillary, then some scattered pale cells with flattened processes, another continuous basement membrane, and finally, the layer of choroidal epithelial cells that actually line the ventricle surface. But here's the key structural distinction for professional understanding. While the capillary endothelial cells are fenestrated and allow some passage, it's the tight junctions between the choroidal epithelial cells that are believed to form the primary structural basis of this barrier.
So again, tight junctions are the crucial element, just in a different cell type here.
Exactly. Tight junctions are the common theme for these protective layers, sealing the gaps, just located differently in the blood-CSF barrier compared to the BBB.
So the tight junctions are the real heroes in both barriers. But what about the interface between the CSF itself, once it's in the ventricles or subarachnoid space, and the brain tissue? Is there a barrier that prevents CSF from just soaking directly into the brain parenchyma?
This is a really crucial point of differentiation, and one that sometimes causes confusion. Unlike the highly selective BBB and blood-CSF barrier, there is no comparable physiological barrier that exists between the CSF and the CNS extracellular compartment that's spaced directly around neurons and glial cells.
So CSF can mix freely with the brain's interstitial fluid.
Pretty much, yes. This is important for understanding how the brain exchanges substances with the CSF nutrients coming in, waste products going out. If you inject vital dyes directly into the subarachnoid space or ventricles, unlike injecting them into the blood, they do readily penetrate and enter the extraocular spaces around neurons and glial cells. Now, there are structures that physically separate CSF from the bulk of the nervous tissue, like the pia-covered surface of the brain and spinal cord, those perivascular extensions of the subarachnoid space along blood vessels, and the ependymal surface lining the ventricles. But these do not act as impermeable physiological barriers in the same way. For instance, the columnar ependymal cells lining the ventricles, while they do have some localized tight junctions, they also have intercellular channels that permit free communication between the ventricular cavity and the extracellular neuronal space just beneath them. There's no basement membrane under the ependymal cells, and the neuroglial cells beneath are often loosely arranged, further facilitating this exchange.
Okay, so pulling this all together, what's the overarching functional significance of all these different barriers and the lack of one at the CSF-brain interface working in concert?
Well, in a healthy, normal state, both the BBB and the blood-CSF barrier function as absolutely crucial, highly selective, semi-permeable membranes. They are the brain's ultimate guardians. They diligently protect the extremely delicate environment of the brain and spinal cord from potentially harmful substances, toxins, pathogens, even just fluctuations in normal blood components that might be circulating systemically. At the same time, they are selectively permeable, ensuring that necessary gases like oxygen and vital nutrients like glucose can enter the nervous tissue efficiently. The lack of a major barrier between CSF and brain extracellular fluid allows for efficient waste removal from the brain into the CSF and perhaps distribution of some substances from CSF to brain tissue. It's a remarkably sophisticated multi-layered filtration, protection, and exchange system, absolutely essential for the brain to function properly second by second.
We've now built a truly comprehensive picture of how this complex system works when everything's in balance. Now, for true mastery, let's explore what happens when things go wrong, when disease, injury, or other factors disrupt this delicate equilibrium. Let's revisit our opening case of the 26-year-old woman with the subarachnoid hemorrhage.
Right. That patient's case perfectly illustrates the clinical relevance of understanding CSF. Her spinal tap or lumbar puncture was critical. When you perform one, CSF pressure is measured normally, as we said, 60 to 150 millimeters of water. What confirmed a true subarachnoid hemorrhage in her case was that both samples of CSF collected were uniformly blood-stained.
Not just the first one.
Exactly. That distinguishes it from an accidental needle puncture during the procedure, where often only the first tube collected might be bloody from local trauma, with subsequent samples clearing up as clean CSF flows out. In a true subarachnoid hemorrhage, the blood is already mixed throughout the CSF within the subarachnoid space before the tap is even done. This blood could have originated from a severe skull fracture tearing vessels, a ruptured aneurysm, a damaged cerebral blood vessel, or even torn brain tissue or meninges. Her subsequent management, identifying the source of bleeding, managing pressure, absolutely hinged on this initial finding from the CSF, and a solid knowledge of the CSF system and the anatomy involved in performing a safe and diagnostic spinal tap.
Another critical clinical sign directly related to CSF pressure is papilledema. What causes this, and why is it such an important indicator for clinicians?
Papilledema is a direct and often quite alarming sign of raised intracranial pressure. Remember how we said the intracranial subarachnoid space filled with CSF extends forward around the optic nerve all the way to the back of the eyeball?
Yes, that extension along the nerve.
Right. So when CSF pressure inside the skull increases, maybe due to an intracranial tumor pushing things around, or an issue with CSF circulation or absorption causing a backup, this elevated pressure gets transmitted along that sleeve of subarachnoid space. It then compresses the thin walls of the retinal vein precisely where it crosses that CSF-filled space to enter the optic nerve. This compression leads to a backup of blood in the retinal vein, causing it to become congested, swollen. The result you see when looking into the eye is a characteristic bulging forward of the optic disc, where the optic nerve head emerges from the retina and edema, or swelling, of the disc itself. That visible swelling is what we call papilledema.
You mentioned it's usually bilateral.
Yes, typically. Because these subarachnoid extensions around both optic nerves are continuous with the single intracranial subarachnoid space, if intracranial pressure is generally elevated, both eyes will typically exhibit papilledema. This bilateral nature is a key diagnostic sign, and it's serious. If this condition is left untreated and the pressure remains high, it can unfortunately lead to damage to the optic nerve fibers, resulting in optic atrophy and, tragically, permanent blindness. So finding papilledema requires urgent investigation.
Then there's hydrocephalus, a condition many people have heard of, which literally means water on the brain. What defines this condition, and what are its primary types and causes?
Hydrocephalus is basically characterized by an abnormal increase in the volume of CSF within the skull. If it's also accompanied by raised CSF pressure, which it often is, it's typically due to one of three underlying problems. Number one, an abnormal increase in CSF formation. Number two, a blockage somewhere in the pathways of CSF circulation. Or number three, a diminished ability of the CSF to be absorbed back into the bloodstream.
Formation, blockage, or absorption.
Exactly. Rarely, you can also encounter hydrocephalus where the CSF pressure is actually normal. This usually occurs as a compensatory mechanism when there's been significant loss or underdevelopment of brain tissue, hypoplasia or atrophy, and the ventricles expand to fill the space. We generally classify hydrocephalus into two main types based on where the problem lies. First is non-communicating hydrocephalus. This occurs when there's a physical blockage somewhere along the CSF circulation pathway between its points of formation at the choroid plexuses and its exit points from the fourth ventricle's foramina, Magendie and Luschka.
So the ventricles can't communicate properly with the subarachnoid space.
Precisely. The CSF cannot flow freely out of the ventricular system. The second type is communicating hydrocephalus. In this case, there is no obstruction within the ventricular system itself or to its outflow into the subarachnoid space. The CSF can freely reach the subarachnoid space, but for some reason, usually impaired absorption, it builds up under increased pressure within that space, subsequently backs up into the ventricles, causing them to enlarge.
Okay, so let's break down the specific causes for each of those types. This is where understanding the detailed anatomy and flow really pays off for diagnosis.
Absolutely. Excessive CSF formation is actually quite rare. When it does happen, it's typically due to a specific type of tumor arising from the choroid plexus themselves, called a choroid plexus papilloma, which just churns out way too much fluid. Much more commonly, we see blockage of CSF circulation, the non-communicating type. The effects depend on where the blockage is. For instance, an obstruction of just one of the interventricular foramina, perhaps by a small colloid cyst, a type of benign tumor will cause distension or enlargement of the lateral ventricle on that side only because CSF can't get out. This pressure can then lead to atrophy of the surrounding neural tissue.
Okay, localized effect.
Right. Now, if there's an obstruction in the cerebral aqueduct, that narrow bridge between the third and fourth ventricles, this can be congenital, present from birth, or caused by inflammation scarring it shut, aqueductal stenosis, or blocked by a tumor pressing on it. Since this is the only path out for both lateral ventricles and the third ventricle, you'll see a symmetrical distension of all three of those ventricles upstream from the blockage.
Makes sense. Both laterals and the third enlarge.
Exactly. If their problem is an obstruction of the median and lateral apertures of the fourth ventricle, maybe they get plugged up by inflammatory exudate from meningitis or blocked by a tumor in the posterior fossa, like a medulloblastoma, then CSF can't get out of the fourth ventricle into the subarachnoid space. So all four ventricles, lateral, third, and fourth, will symmetrically dilate. And finally, if the subarachnoid space itself becomes blocked, for example, by widespread inflammatory exudate from meningitis gumming up the pathways, or after a large subarachnoid hemorrhage where blood clots obstruct flow, then the entire ventricular system can become distended because CSF can leave the fourth ventricle exits but can't effectively circulate over the brain surface to reach the absorption sites. This would be technically considered a form of communicating hydrocephalus, as the ventricles do communicate with the subarachnoid space, but the downstream flow is blocked.
Right, that clarifies the blockage types. And what about the third category? Issues with CSF absorption leading to communicating hydrocephalus.
Right. Diminished CSF absorption happens when there's interference at the arachnoid granulations, those key sites where CSF returns to the venous sinuses. This interference can be caused by several things. Inflammatory exudates from meningitis can physically clog the villi. Venous thrombosis, a blood clot within the dural sinuses, can raise the venous pressure so high that the gradient for CSF absorption is lost or reversed. Direct pressure on the venous sinuses themselves, maybe from a skull fracture or a tumor, can impede flow. Even obstruction of the internal jugular veins down to the neck can back up pressure into the sinuses and hinder CSF reabsorption, all lead to CSF building up.
Given all these potential problems and locations, how do clinicians actually investigate the ventricles and CSF system when they suspect an issue? What imaging techniques do they rely on to visualize these complex internal structures?
The modern workhorses, the standard, safest, and easiest methods today are definitely computed tomography, or CT scans, and magnetic resonance imaging, MRI.
CT and MRI.
Yes. These techniques are incredibly effective. They can clearly demonstrate the ventricular outline, show any enlargement, distension, or distortion from pressure or masses. They can often pinpoint the location of a blockage and frequently identify causative lesions like tumors, cysts, or evidence of hemorrhage or inflammation. They are really the go-to tools. Historically, though, and sometimes still used in very specific circumstances, perhaps when dynamic flow information was needed or if CT-MRI were unavailable or contraindicated, intracranial pneumography was employed.
Pneumography, involving air.
Yes, exactly. This involved carefully replacing some of the patient's CSF with air, or sometimes oxygen, which would then outline the fluid spaces on X-ray images. An encephalogram involved introducing the air via a spinal tap in the lumbar region. The air would rise up into the head and could visualize not only the ventricles, but also the subarachnoid spaces over the cerebral gyri. It was quite uncomfortable for the patient, though. A ventriculogram involved introducing air directly into one of the lateral ventricles, usually through a small burr hole drilled in the skull, or sometimes through an infant's fontanelle or suture line. This visualized only the ventricles themselves, upstream from the injection point. While these air studies are much less common now due to the superb detail and safety of CT and MRI, understanding these historical techniques is still part of having a complete professional grasp of how the field evolved.
Beyond imaging the structures, CSF analysis itself, actually sampling the fluid, is a hugely powerful diagnostic tool. How is CSF analyzed when disease is suspected, and what specific insights can it provide?
Absolutely. Analyzing the CSF itself is often crucial. The first thing you assess during the spinal tap procedure is the opening pressure reading. As we've hammered home, normal is typically 150 millimeters of water. Increased pressure is a critical finding, potentially indicating serious conditions like meningitis, inflammation increases fluid pressure, or anything that increases the volume within the fixed space of the skull brain, edema swelling, a tumor, an abscess, or a hematoma, blood clot.
So pressure is a key vital sign here.
Definitely. There's also a maneuver called Queckenstedt's sign, sometimes used to test for a blockage in the spinal subarachnoid space. Normally, if you gently compress the internal jugular veins in the neck, CSF pressure should rise transiently because you're temporarily inhibiting venous drainage from the head and thus CSF absorption. If the pressure fails to rise upon compression, it strongly suggests a block somewhere below the base of the skull, like a spinal tumor obstructing the space. Then, the visual appearance of the CSF fluid collected is highly informative. Normally, it should be crystal clear and colorless, like water. Cloudiness or turbidity immediately suggests the presence of white blood cells, usually polymorphonuclear leukocytes, pointing towards a bacterial infection or possibly very high protein levels. Gross blood, if it's uniformly distributed across multiple collection tubes, strongly indicates a subarachnoid hemorrhage, as we discussed in our initial case, distinguishing it from just nicking a vessel during the tap. And xanthochromia, a distinct yellowish coloration of the CSF supernatant after speeding down any red cells, is also very significant. It indicates the presence of bilirubin, a breakdown product of hemoglobin, which typically appears several hours after bleeding into the CSF has occurred and is considered definitive evidence of a preceding hemorrhage.
So visual cues, pressure, and cell counts offer immediate critical insights. What about delving deeper into the cellular and chemical composition?
Indeed, a microscopic cell count is standard. A normal CSF sample will have very few white blood cells, typically fewer than 4 or 5 lymphocytes per cubic millimeter, and essentially no red blood cells or polymorphs. In bacterial infections, especially acute bacterial meningitis, the white cell count skyrockets, often into the thousands, and the predominant cell type will be polymorphonuclear leukocytes, neutrophils, the bacteria-fighting cells. Viral infections of the CNS, like viral meningitis or encephalitis, on the other hand, typically show a more moderate increase in white cells, and the predominant cell type is usually lymphocytes. Even a slight rise in lymphocytes can be significant, sometimes pointing towards conditions like cerebral tumors, brain infarction, stroke, or inflammatory conditions like multiple sclerosis. Chemical markers are also vital. Glucose levels in CSF are normally about 50–60% of the level in the blood measured concurrently. In acute bacterial meningitis, CSF glucose may drop dramatically, sometimes even disappearing completely, because the bacteria are rapidly consuming it. Interestingly, in most viral infections, CSF glucose typically remains normal.
That's a key differentiator.
A very important one. Protein levels in CSF are normally very low, much lower than in plasma. An increase in CSF protein suggests a change in the vascular permeability of the barriers, often seen in conditions like tuberculous meningitis or poliomyelitis, and a specifically elevated level of one type of protein, gamma globulin, which includes antibodies or immunoglobulins, often measured as the IgG index or by looking for specific patterns called oligoclonal bands, is a key indicator for multiple sclerosis. This reflects immunoglobulin production directly within the central nervous system itself, a hallmark of MS.
And these detailed analyses can point to very specific conditions and sometimes even hint at the precise location of the problem.
Precisely. For instance, if there's a subarachnoid space blockage in the spinal canal, say from a spinal cord tumor or a tumor of the meninges compressing the space, you might observe not only the lack of rise with Queckensteck's maneuver, but also reduced or absent normal pressure variations that usually occur with the patient's pulse and respiration. The CSF obtained from below the block might also be distinctly yellow, gansochromic, and due to extremely high protein content that has become trapped, may even clot spontaneously upon standing a phenomenon known as Freund syndrome. If we consider fourth ventricle tumors, like ependymomas arising from the ependymal lining, or medulloblastomas often occurring in the cerebellum nearby, their growth can have profound and varied effects. They might invade the cerebellum directly, leading to cerebellar deficiency symptoms like ataxia, lack of coordination, tremor, or difficulties with balance and gait. Or, crucially, they might press downwards onto the vital nuclear centers located just beneath the floor of the fourth ventricle. Remember the hypoglossal and vagal nuclei we identified there?
Right, controlling tongue, swallowing, autonomic functions.
Exactly. Compression of these centers can manifest with devastating symptoms affecting tongue movement, swallowing reflexes, respiration patterns, heart rate regulation, and blood pressure, control a truly life-threatening neurological emergency requiring immediate attention. Understanding that specific anatomy is key.
Finally, let's tie this all back to the blood-brain barrier and its direct impact on clinical practice, especially concerning brain trauma, drug delivery strategies, and brain tumors. This is where understanding the BBB moves from intricate theory to direct patient care implications.
Yes, the BBB's integrity, or lack thereof, is hugely relevant clinically. Any significant injury to the brain, whether it's direct physical trauma like a concussion or contusion, an inflammatory process like meningitis or encephalitis, or exposure to certain chemical toxins can cause a temporary or sometimes permanent breakdown of the BBB in the affected area. This breakdown is clinically very significant because it allows substances, including large molecules like plasma proteins or potentially harmful blood components, which are normally excluded, to diffuse freely into the nervous tissue. This can contribute to secondary injury processes like brain edema.
And what causes the breakdown?
It's believed to be due either to direct physical destruction or damage to the vascular endothelial cells themselves, or perhaps more subtly, a disruption of those crucial tight junctions that normally seal the gaps between them.
And when it comes to getting medications into the brain, the BBB presents a formidable challenge for drug delivery, doesn't it? This must be a huge focus in neuropharmacology.
It absolutely is a cornerstone of the field. Take a common antibiotic, like penicillin, for example. Under normal circumstances, only a very small amount enters the CNS when given systemically, e.g. intravenously. This is actually fortunate in some ways, as very high concentrations of penicillin can be toxic to the brain, causing seizures. However, this poor penetration poses a major problem when trying to treat CNS infections like bacterial meningitis. In meningitis, the inflammation of the meninges does increase local BBB permeability somewhat, allowing more drug to get in than usual. But even then, achieving truly therapeutic concentrations in the CSF and brain often requires administering very large intravenous doses of penicillin, much higher than you'd use for an infection elsewhere in the body.
So the inflammation helps a bit, but not always enough.
Right. Conversely, some other antibiotics, like chloramphenicol or many sulfonamide drugs, are known to penetrate the BBB much more readily, making them potentially better choices for certain CNS infections. The general rules apply. Lipid-soluble substances tend to cross readily. Think of the intravenous anesthetic thiopental, which acts very quickly on the brain because it's highly lipid-soluble, or tertiary amine drugs like atropine, which can have central nervous system side effects because they cross. But water-soluble substances, especially those that are ionized or are large, generally cannot cross effectively. Examples include neurotransmitters like exogenous norepinephrine. If you inject it, it won't get into the brain well. Or quaternary ammonium compounds like atropine methyl nitrate, a charged version of atropine that lacks the CNS effects because it can't cross the BBB. Also, drugs that bind tightly to plasma proteins, like the anti-inflammatory drug phenylbutazone, effectively become very large drug protein complexes, and these complexes generally cannot cross the barrier.
That makes drug design tricky.
Extremely. The classic, elegant example that perfectly illustrates both the problem and a clever solution is in treating Parkinson's disease. The core problem in Parkinson's is a deficiency of the neurotransmitter dopamine in certain brain areas. But simply giving dopamine as a drug doesn't work because dopamine itself cannot cross the BBB effectively.
Right.
However, its metabolic precursor, L-DOPA, levodopa, is able to cross the BBB readily using an amino acid transporter. Once inside the brain, L-DOPA is then converted into dopamine by enzymes present there, effectively bypassing the barrier and successfully replenishing dopamine levels to manage the symptoms. It's a profound example of rational designing a drug to circumvent the BBB for therapeutic effect.
Fascinating. And what about brain tumors? Does the BBB behave differently in cancerous tissue within the brain?
It's a complex picture, but yes, often it does. Brain tumors, particularly aggressive, high-grade malignant ones like anaplastic malignant astrocytomas and glioblastomas, as well as many secondary metastatic tumors, cancers that spread to the brain from elsewhere, frequently possess blood vessels that lack a functional, intact BBB. Their vessels are often leaky, abnormal.
So the barrier breaks down in the tumor itself.
Often, yes. This characteristic can actually be exploited in diagnostic imaging. When contrast agents, like gadolinium for MRI, are injected intravenously, these agents normally cannot cross the intact BBB, but they can leak out of the abnormal vessels within these types of tumors, causing the tumor to light up or enhance on the scan, helping to delineate it. However, it's important to remember that this isn't universally true for all brain tumors. Some slow-growing tumors, like low-grade gliomas, often retain relatively normal vascular barriers, which can make them harder to see with contrast enhancement and also harder to treat with chemotherapy drugs that rely on BBB penetration. It adds another layer of complexity to diagnosis and treatment planning.
Wow. So from the intricate C-shape of your lateral ventricles, navigating through the foramina and aqueduct, to the finely tuned filtration of your choroid plexuses producing that vital CSF, and then the vigilant guardianship of the blood-brain barrier selectively controlling entry. We've journeyed through a truly remarkable internal world today, understanding it at this depth, really grasping the connections, the flow, the barriers, the clinical correlations, as you listening have just done, truly puts you in a different league. It's a testament to the body's incredible engineering, and it provides a profound foundation for understanding the brain in both health and disease.
Indeed. This comprehensive deep dive into the ventricular system, CSF dynamics, and these crucial protective barriers isn't just about memorizing anatomical parts or pathways. It's about appreciating the complex dynamic interplay that maintains the brain's incredibly delicate and exquisitely stable environment. It really highlights how quickly even subtle imbalances or disruptions in the system, a small blockage, impaired absorption, a leaky barrier, can lead to profound clinical issues. And conversely, how this targeted, detailed knowledge, the kind we've aimed for today, is absolutely essential to guide accurate diagnosis and develop effective treatments. You now genuinely have the kind of insights that define an elite professional in this field.
It really makes you stop and think about all the unseen, intricate forces at play within us constantly, doesn't it? As you go about your day now, maybe consider this. How does this incredibly stable, protected internal environment, meticulously maintained by these precise barriers and fluid dynamics we've discussed, how does that foundation truly shape our perception, our thoughts, our memories, our very consciousness, moment by moment? Something to ponder. Thank you so much for joining us on this deep dive. Stay curious, keep asking questions, and keep exploring the incredible insights waiting to be discovered within the human body.